go to our next speaker, a good friend of mine and a very prolific speaker and an interventional cardiologist of repute, Dr. Sandeep Bansal from Delhi, and a professor HOD at, I think, Vardhaman Medical College and a senior cardiologist at Safdarjung Hospital. Dr. Bansal will speak to us on what is the role of beta blockers with all this new things that are coming up. It's a very important. Yeah. Thank you, Bansal. Yeah.
Thank you so much. Coming after Dr. Gurpreet's just such a great talk, one may find my talk a little boring because there's not much new in terms of beta blockers and heart failure over the last few years. Nonetheless, I'll try and do my best. So when we sift through the basics, we understand that the heart rate control, which is so very important in management of heart failure, is primarily a balance between the parasympathetic and the sympathetic systems. The parasympathetic decreases the heart rate and the sympathetic increases the heart rate, and they together are extremely important even in the setting of heart failure for the control of heart rate. We also understand that the three major indications for beta blockers, the drug group that has been assigned to me, are highlighted here. They are useful in coronary artery disease, which may be acute coronary syndromes, as also in stable coronary artery disease. And the third is heart failure. And it has been seen that particularly in patients with heart failure with reduced ejection fraction, it reduces mortality, reduces hospitalization. And as we note in the recent heart failure trials, at least maybe over last 15 to 18 years, the usage of beta blockers has definitely been over 80% in majority of the studies. So beta blockers have been used widely. So this is actually just about a couple of years ago, the role of beta blockers in the three conditions that we see here. And as we can see here in the HEF-REF, it is clearly shown to be beneficial. There would be groups of coronary artery disease where it tends to benefit, but there would be some in which it actually may be harmful. In hypertension, it is certainly not the first line drug in most of the patients, except it may rather be the fourth or the fifth line drug in majority of the patients. And here we see what it does. This group of drugs, they decrease the neurohumoral activation, they decrease the heart rate. They, however, increase the central pressure, and they also increase the insulin resistance and are associated with lipid changes and weight gain, which are side effects. And that is why there are groups of patients where they are clearly beneficial, and there are groups of patients where they're not beneficial or rather may be harmful. Now, the status of beta blockers in heart, this has been discussed. Now, if you are beyond group B, and we see here that beyond group B, there is a fairly substantive proportion of heart failure population. Across the board, the beta blockers are, and this is to put in another way, as Dr. Gurpreet was discussing, in stage A, actually, the ACE inhibitors or ARBs would be indicated, and in diabetics, the SGLT2 inhibitors. But beyond stage B, the beta blockers are an important group, and as was highlighted, one of the four pillars of management of heart failure is the beta blocker. Now, when we look at beta blockers in heart failure with reduced ejection fraction, there are various mechanisms which have been, talked about, including the decreasing of mechanical stress, their action against the neurohumoral activation, and there are many, drugs which actually have anti-inflammatory and anti-apoptotic and oxidative stress decreasing effects of beta blockers, which work in tandem, and sometimes they interrelate each other. Now, there are three major studies, as was highlighted in one of the points which was made by one of the speakers, that there are three main studies using three different drugs, that is bisoprolol, metoprolol succinate, and carvedilol, which have clearly shown that whatever parameter we look at in terms of heart failure with reduced ejection fraction, whether it is all-cause mortality, sudden death, all hospitalizations, or only heart failure hospitalization, every single parameter is statistically significantly reduced. And if we talk of the total sum, it has been seen in a meta-analysis that it causes approximately 30% reduction in overall mortality, 30% reduction in sudden death, and approximately 34% reduction in deaths from pump failures. And each one of these is really significant. When we talk of why or which beta blockers help, we know that if a beta blocker has intrinsic sympathomimetic activity, it does not help. The two great examples of this are nebivolol and basindolol. These were the two drugs which were tried in heart failure patients but did not prove their mettle. On the other hand, a combination of beta-1 receptor selectivity without sympathomimetic activity, if we look at bisoprolol, metoprolol, and of course carvedilol has got a very dominant alpha blocking action also. So these are certain properties which help in this. So if we look at specific properties, so selectivity, blockade of the other beta-2 receptors, and additional vasodilatory properties. These are certain properties of beta blockers which have been found to be beneficial in failure. And as I was saying, there are three main drugs, and there have been several studies using this. Bisoprolol using Cibis, Cibis-2, and Cibis-3, using metoprolol succinate, and we have trials with this nebivolol, particularly in the elderly patient, and we've had some interesting trials using carvedilol, which have been shown to be extreme. And so based on these, as I said, if your patient is in stage A, you don't use it as first-line drugs, but you use all the beta blockers in management of heart failure. If you have a coexisting comorbidity in the form of hypertension, in the form of coronary artery disease in particular, and these are the recommended doses, the initial doses, and the maximally recommended doses. Although in a lot of patients, we use maximally recommended doses. This is another slide to basically highlight what is the role of different beta blockers and the properties that they have. And majority of these beta blockers are almost equal in terms of reduction in the mortality as well as in the reduction in symptoms. Based on these, both the American and the European societies recommend the usage of beta blockers. Now, if we talk of certain nuances, what is exactly new? Because they've been around for quite some time, we are now in a position to answer certain questions or handle certain nuances about them. Now, the first would be if you have to choose between beta blockers or the ACE ARB, which one should be used? It has been clearly shown that you can use either one of them. The effect or the benefit is similar. But in patients who have very dominant tachycardia with a borderline pressure, we know that the newer algorithms, Dr. Gurpreet did highlight that there are newer algorithms which say that one could start actually with beta blockers along with the SGLT2 inhibitors. It is also now what happens if we use these drugs in patients with, if we use these drugs in patients with atrial fibrillation, do they benefit? The net sum does show that patients on metoprolol do benefit if they have atrial fibrillation. The other thing is, do they improve quality of life as well as quantity of life? And the answer is yes, they do improve both quality of life and quantity of life. What is also new, we know that conventionally they have been sequenced in the manner, the drugs have been sequenced in the manner in which they appeared in the history of medicine for the management of heart failure. That is, it was a 4 or a 5-step approach. We now know that there are different approaches using rapid sequencing. As I said, start with a beta blocker plus SGLT2 inhibitors. Within a week or two, add the ARNI, and within another 2 weeks or 1 week, add MRA, and achieve the total blocker to the total 4 within 4 weeks. One slide that kind of got missed out in the melee is, whether these are useful in patients with MREF or HFpEF. At the present time, the beta blockers are not recommended in patients who are initial presenters with MREF or HFpEF, unless there is a comorbid condition, necessitating their use. However, in patients who are improved ejection fraction from HFrEF, they turn into MREF or HFpEF, a decision needs to be made on patient-to-patient basis. But in a large number of these patients, the beta blockers may need to be continued. And this is my final slide. This is actually just 2 days old. And this actually shows also as to how the sequencing of different drugs affects heart failure, hospitalization, and all-cause death. And we find that the yellow, that is the beta blockers, they are an important component of the rapid sequencing of drugs to be used in heart failure with reduced ejection fraction. Thank you very much.